Alright, so just kind of summarizing the pros of dabigatran versus warfarin. You're looking at probably similar to maybe even better efficacy as pretty well managed warfarin. And well managed warfarin means you get in that target INR range about 65% of the time. Believe it or not, that's considered well managed warfarin. You do not need to do routine monitoring. In fact, there's no easy way to do any monitoring. There's very predictable dosing. You don't have to change the dose all the time, really just basing it on renal function, and that's all. Very few drug interactions, and a little bit quicker onset than warfarin because you don't have to wait for the circulating clotting factors to die off since you're only, with warfarin, since you're only preventing their formation. One of the cons is, of course, cost. It's a brand new drug. It's about $225 per month versus only about $55 for warfarin, which includes getting INR monitoring, assuming about once a month. There's no antidote for quick reversal. You have to dose it twice a day, which isn't great because we certainly don't want people to be non-compliant on a drug that's preventing strokes. Warfarin's once a day, so we've got a twice-a-day drug, which we know is a less compliant regimen. GI side effects, more common. Again, that gets to compliance. Patients may get dyspepsy and quit taking the drug, putting them at risk of a stroke and not tell you about it as the prescriber. And so you think everything is hunky-dory, and in fact they're skipping half their doses. And you can't check it. You can't just pull an INR and see how they're doing. You just have to take their word for it. And we don't have any good data right now with severe renal impairment or patients that are pregnant. If you want to convert somebody currently on warfarin to dabigatran, all you do is stop the warfarin and then you start the dabigatran once the INR drops down to 2 or less. If somebody is on dabigatran and for some reason you want to convert them back to warfarin, then like we do typically with the warfarin, we have to start that a few days early since it takes a while to get its motor going. And so we start warfarin in 3 days prior to stopping the dabigatran. If the person's creatinine clearance is 31 to 50, then we're going to stop the warfarin only 2 days prior. And if their creatinine clearance is really poor and is 15 to 30, then we're going to stop the warfarin 1 day prior. I'm sorry, start the warfarin 1 day prior. Both those should say start. I mentioned earlier Ipravask or Desarudin, the brand new sub-Q DTI. Right now it's just used for DVT prevention after hip replacement surgery. It's given BID, much like the low molecular weight heparins are. Interesting information tidbit here about Ipravask, however, is that people can form antibodies to it. And essentially, that means that Ipravask or Desarudin is a one-time drug, one course of therapy. Re-challenge with this drug after initial use can cause a very poor outcome via an anaphylactic reaction. It's also extremely expensive versus enoxaparin or Lovenox, about $2,400 for a course of therapy versus about $400 for a course of therapy with Lovenox. Efficacy looks pretty comparable with the stuff to enoxaparin. We saw DVT occur about 18% of the time on patients that were taking Desarudin versus about 25% in this study that were taking Lovenox. So about the number needed to treat there of 10 to prevent 1 DVT, at least in this trial. I'd call efficacy probably similar and not really say based on this one trial that it's a whole lot better. Very similar rates of bleeding to Lovenox. It's not really any safer there. One nice thing, since this is not a low molecular weight heparin, is that we do not see any risk of heparin-induced thrombocytopenia. I mentioned the anaphylaxis risk. Pregnancy category C with this stuff. Alright, on to a new category here, factor Xa inhibitors. Erixtra or fondaparinux is actually based on, it's a synthetic form of that pentasaccharide complex that allows heparin to work, but this is synthetic, so it's an indirect factor Xa inhibitor. It's used and indicated very similarly to the low molecular weight heparins, which is essentially after hip or knee surgery to prevent DVTs. You don't have to monitor this stuff. Very low risk of HIT, although there have been 3 cases reported. We're not really sure what's going on there, but because of that, we can't, across the board, recommend treatment of patients that have had HIT with Arixtra. They probably will do just fine, but if somebody actually has HIT and we need to keep them anticoagulated, we're still going to go to direct thrombin inhibitors, the IV drugs like argatroban, and we're not comfortable enough yet to say that you could use fondaparinux in that setting. It's given once a day, pretty easy to dose. So this is exciting. There is a brand new factor Xa inhibitor. It just came out in the summer of last year called rivaroxaban. It's been out in the pipeline for a long time. Brand name is Xarelto. It's easy to remember how this stuff works because the brand name starts with the symbol for Xa. This is a once a day drug as opposed to Pradaxa. It competes directly with Pradaxa and warfarin. It's used for 2 things. This stuff came out with an indication for DVT prophylaxis after hip knee surgery, but now it also has FDA approval for prevention of PEs in the setting of atrial fibrillation, just like Pradaxa. So it's got 2 indications now, competes head-to-head with warfarin and Pradaxa. Tabs can be crushed if somebody has a GI tube, as long as that tube is not in the small intestine, because in that instance, the absorption is greatly reduced. In the clinical trials, it looks like Xarelto is actually a little bit more effective than enoxaparin is, with a similar bleed risk, so that's pretty good. Very short onset of action. Relatively short offset, about 5 to 9 hours. You compare that to fondaparinux, that's about 20 hours. Still just given once a day. Very bioavailable. There's no effect on giving food or on what the gastric pH is. As I mentioned, if it's deposited directly in the small intestine, you only get about half the dose. Elimination is 70-30, renal feces. Very highly protein bound, so you can't get this stuff out of the blood by dialyzing it. So that's kind of a downside. There's no antidote to this, and you can't use dialysis to get rid of it. "10 milligrams q day, starting about 6 to 10 hours after surgery. If somebody has significantly impaired renal function, less than 30 mils per minute, then it's contraindicated. It's given for 12 days for knee, or 35 days, where it gets really expensive, for hip replacement surgery. Unlike Pradaxa, we've got a few drug interactions with this stuff. Drugs that are P-glycoprotein inhibitors, and also, at the same time, strong inhibitors of cytochrome P450-3A4, then you can see significantly increased levels and possible bleeds. These are drugs like ritonavir, the AIDS drug, the azole antifungals. If the drug is a P-glycoprotein transporter inhibitor and a moderate CYP3A4 inhibitor, and there's renal impairment going on, we need to use caution. So if those 3 factors are all present with drugs like amiodarone or diltiazem or verapamil, then we need to be very careful and look for a bleed. 3 for inducers, like very widely known rifampin, carbamazepine, or phenytoin. You would probably have to double the dose to 20 milligrams q day, because these inducers are going to clear that rivaroxaban through the hepatic system a lot faster. It does prolong the APTT, PT, and thrombin time. It does affect anti-Xa activity, but we really, again, don't know their predictive value of those. They're not used quantitatively, they're used qualitatively. So again, just like with Pradaxa, These measures tell us if the drug is on board. They don't tell us very reliably to what degree the patient is anticoagulated. We can't reverse the stuff just like we can't with Pradaxa. But that's the same thing for fondaparinux and for apixaban, the new agent that's coming out, the new 10A inhibitor. Hasn't hit the market yet. You need to discontinue this stuff about 24 hours prior to any sort of an invasive procedure or surgery. Like we did with Pradaxa, just kind of a chart here of what we might try if somebody is actively bleeding on this stuff. Nothing has really been shown to be very effective other than just local control measures to support hemostasis. In a trial that compared Lovenox, 40 milligrams a day, to rivaroxaban and hip replacement, a big study, 10,000 patients, which is very, very large for a drug company study. We saw VTEs in about 1.1% of patients versus 3.7% of patients on Lovenox. If you calculate, and I encourage you to practice here, the NNT on that, you come out with about 38. 38. That's over 35 days of treatment. So if you treated 38 patients with rivaroxaban for 35 days, you would prevent 1 VTE versus treating those patients with Lovenox. And knee replacement, even better, about an NNT of 11 over 14 days of treatment. It was compared to warfarin in an AFib trial. 14,000 patients in this trial. Again, these are huge trials. A lot of times we see drug trials with 1 or 200 patients in it, and sometimes 15 or 20 patients. So these are very large trials, which gives a lot of statistical power to the results. Here they compared 20 milligrams per day, which is the dose for AFib, the new indication that it got, versus warfarin, trying to get warfarin's INR between 2 and 3. What we found here is about a 1.7% versus 2.2% incidence of stroke or systemic embolism. NNT there is about 200, and statistically this was non-inferior, which means there's no evidence of it being better than warfarin, but it wasn't worse. Very similar bleeding rates. Interesting information here is that the FDA initially was heading towards not approving Xarelto because that clinical trial, as I mentioned before, typically good INR control in a patient on warfarin is about 65% of the time, being between 2 and 3. In this trial, patients were only in that range of 2 to 3 on warfarin about 55% of the time. So the drug, rivaroxaban, may have looked better than it should have because the patients here apparently were not treated to goal very well with the warfarin. So suboptimal warfarin treatment in this drug showed non-inferiority. So possibly we've overstated the benefit versus warfarin in this trial. Bleeding rates look real good and similar with this drug versus enoxaparin. Pregnancy category C. Cost is about $8 per 10 milligram tablet. The AFib dose at 20 milligrams per day is going to be more expensive, about $413 per month, which is a heck of a lot more than we would pay for warfarin. Kind of on par with what the low molecular weight heparins cost. I'm going to let you kind of read through these because I'm going to try to finish this up and not have to make a part 4. Pros and cons are pretty straightforward. And just read through these antiplatelet agents. One thing I want to kind of hammer on a little bit is the issue of Plavix being a prodrug and needing CYP2C9 activation to convert it to its active form, and the drug interactions and the genetic polymorphisms on that P450 enzyme that can cause reduced efficacy of the drug.